Ladies and gentlemen, at the outset, I would like to thank GVK sir for having me here to talk on the subject pruritis in special situations. Pruritis is a disturbing stimulus that causes desire to scratch the affected skin area. It can be generalized or localized. Based on its chronology, it can be acute, that is less than 6 weeks, or even chronic when it is more than 6 weeks. There is a forum called the International Forum for the Study of Itch, that is called the IPSI, which classified chronic pruritis into 6 categories: dermatological condition that can cause pruritis, systemic condition, neurologic condition, psychogenic condition, mixed, and others. Though it looks like diabetes falls under the systemic category, it can also cause these changes in the skin, that is dermatologic, as well as the neuropathic mechanism by which it can cause pruritis. The prevalence of the skin disorders in diabetes, which can range from 30 to 97% in various regions, depends on the ethnicity. There is a study which was conducted by Al-Mutari et al. Pruritis was reported as the second most common cutaneous manifestation, affecting 49% of the patients with diabetes. It is quite embarrassing for any patients with diabetes to have pruritis. Sometimes we commonly see our patients saying that they had a scratch due to the pruritis, which has caused some wounds, superficial wounds, got infected, cellulitis, and even it might lead to diabetic foot ulcers. In some of the patients, these have ended up in amputation also. Many patients with pruritis, they also say sleep disturbances, which can have adverse effects on the metabolism, disruption in circadian rhythm also. The proper understanding of the pathophysiology of pruritis can aid in its timely management, thereby improving the quality of life. Now let us see the pathophysiology. For itching to happen, you need to have a stimulus, either in the form of immune dysregulation, neuropathy, toxins, or dysbiosis, or oxidative stress. This can stimulate the immune cells, keratinocytes, and sensory nerve endings by releasing inflammatory mediators, neuromediators, or peptides, which eventually culminate in two pathways. One is activation of the histaminergic pathway through TRPV1 and phospholipase C, which mediates mechanically through insensitive C fibers in dermoepidermal junction. The another non-histaminergic pathway, which is mediated by the part 2 and TRPV1, again mediates through the sensitive C type fibers in the epidermis. In addition to that, we have a lot of inflammatory mediators, many interleukins, serotonin, kinase, histamine, opioid peptide have also been implicated in the pathogenesis of pruritis. I've been telling about the C fibers. What is this C fiber does it? These are all the C fibers which senses pruritis, itching in our body. They relay in the dorsal horn of the spinal cord, then project to the thalamus, finally into the somatosensory cortex. This information is also passed to the motor cortex to induce the perception of the pruritis and scratching, thereby initiating the pruritis scratch cycle. Now, what are all the pathophysiological factors that can cause pruritis in patients with diabetes? Now, see one by one, with skin barrier disruption as the first one. Transepidermal water loss is high in patients with diabetes. And they also have dehydration, decrease of ceramides, free fatty acids, cholesterol in the stratum corneum, and decreased sebaceous gland activity, which can eventually make the skin scaly, rough, cracked, and fissured, dry skin. This is what we see in most of our chronic diabetic patients. And this dry skin makes vulnerable to get fissures, infections with bacteria, fungus, and as well as the chemical damage. Once the patient starts scratching, it initiates the inflammatory reaction and eventually will end up with pruritis scratch cycle. The diabetic neuropathy also can cause pruritis through damage to the nerve endings type C and type A delta. The damage can happen due to various reasons, including the oxidative stress, inflammatory stress, advanced glycation end product, which could cause mitochondrial dysfunction, and arising due to hyperglycemia. The decreased expression of the cannabinoid 1 receptors in the dorsal root ganglia also can lead to loss of neuroprotective effect. Autonomic neuropathy is another common condition where the patient exhibits anhidrosis in the lower part of the trunk, mainly due to the pseudomotor dysfunction. The sensory nerve endings around the sweat glands will get disrupted and resulting in reduced hydration of the skin. This can lead on to dry skin and cracked feet. CKD is another important comorbidity which can cause CKD-associated pruritis. The proposed mechanisms in patients with CKD are the deposition of the uremic toxins, calcium, phosphates, magnesium, and albumin. Peripheral neuropathy and immune dysregulations are the other two components which add on to the fuel to the fire in patients with pruritis associated in patients with diabetes. The high levels of oxidative stress also can lead on to the development of pruritis in patients with diabetes. Anti-diabetic drug, commonly the biguanide, sulfonylurea, SGLT2 inhibitors also can sometimes cause pruritis. The cholestasis is the proposed theory by which biguanides can cause pruritis. Other pruritogens for this theory include the accumulation of the bile salt in the dermis, bilirubin, the gut microbiome, and the lysophatatic acid. So these are all some of the reasons by which the drugs also can cause pruritis. Coming to the management of the patients with pruritis, that includes the adequacy of the glycemic control. And we can use some emollients also. That is one of the main core in the therapy of pruritis in patients with diabetes. These emollients, particularly which contains urea, which keeps the skin moist, flexible, supple, and soft by maintaining the lipid layer. And it can also help the patient to develop nerve growth factor, and the increases the number of penetrated intraepidermal nerve fibers. The other non-pharmacological measures that includes keeping the skin clean, keeping the house more humid during winter, and wearing loose and soft clothing, using mild shampoo or moisturizer soaps and skin lotions. And we need to check the feet every day for sore. That is more important. Some of the don'ts include sauna. This is becoming very popular nowadays. The steam bath even if they are available in gyms. Frequent washing with the alcohol-based sterilizer also can result in dry skin and can cause more itching. Very hot bath and showers also can cause scratching and itching. Using feminine hygiene spray, ice packs, and alkaline cleanser can worsen the pruritis in patients with diabetes. Coming to the pharmacological therapy, as it involves the irritation of the nerve endings, particularly the C fibers and the A delta, the neuropathic drugs, commonly the gabapentin, pregabalin, are very good agents against these pruritis. In some patients, may respond to antioxidants like vitamin C and E and alpha-lipoic acid. We don't have cannabinoids, but we do have a good group of drugs called SSRI. These SSRIs, commonly the sertraline, amitriptyline, mirtazapine, or paroxetine or nortriptyline, are the good agents to prevent pruritis. In addition to that, they also help the patient to get anxiety and depression being treated with these agents. The another group of agents include capsaicin, which acts through the TRPV1 and reduces the substance P. Mast cell stabilizers like bromelain sodium, which are available in both topical and oral preparations, also can be effective in treating patients with pruritis. Ladies and gentlemen, the antihistamines, they do not have much role to play in patients with itching in patients with diabetes. In fact, these antihistamines can cause more dryness, can worsen the pruritis. So once the patient is developing a pruritis, particularly the chronic pruritis, the neuropathic drugs are the common drugs which are used to control the itching as well as the pruritis. So with this, I thank again the organizers for having me here. Thank you.